So there's a concern for an acute pulmonary embolism. The team that is managing the patient requests a CT angiogram of the chest to confirm their clinical suspicion. However, upon further discussion with the OB team, there is a recommendation not to move the patient off of the labor floor because there's no time to perform a CT angiogram of the chest because she is in advanced labor, 9 centimeters dilated, and will be delivering in a short period of time. And they really cannot risk transferring her away from access to services. So the question really becomes, when there is a strong clinical suspicion for an acute pulmonary embolism intrapartum in labor, how do we most safely and effectively manage the patient as well as the fetus? And really depends on the stage of labor that a woman is in and her parity. So depending on how far along the patient is in the labor, we need to make a determination. Is a vaginal delivery going to be imminent, or will the patient require a cesarean? So if somebody is in advanced labor and an operative vaginal delivery is possible, then one could consider, as is the case here, to have a multidisciplinary approach and deliver the patient safely by performing an operative vaginal delivery. The reason for doing an operative delivery is it shortens the second stage of labor, but it's important to have all the appropriate resources available, including cardiology, invasive cardiology, and CT surgery. So one should consider cannulation of the patient for possible ECMO, and then operative vaginal delivery most safely performed in the cardiac OR. We chose that option for this patient because, again, she was very advanced. However, had this diagnosis been suspected much earlier in labor, then a vaginal delivery would be very remote, potentially hours away, and a cesarean delivery would have been the most prudent option to expeditiously deliver the fetus to allow for appropriate therapy acutely for the mother. In that case, one would again cannulate the patient for the potential for ECMO and then perform cesarean in the cardiac setting, in a cardiac OR. Of course, there are many decisions to be made about anesthetic modalities and the impact of potentially general anesthesia in the context of extreme right-sided heart pressures. But performing an expeditious delivery allows for definitive therapy of the mother, which obviously could include therapeutic anticoagulation, potential thromboembolectomy, interventional radiologic procedures will be discussed in a short while, and then potentially more definitive surgical management. But again, in this case, given the fact that she was in the late stages of labor, we were able to perform an operative vaginal delivery, cannulate the patient prior to performing that, and then start immediate therapeutic anticoagulation and complete further imaging to allow definitive therapy.